just the posterior part is a little bit left here. You can clear that. Yeah, we'll send it to histology as inferior turbinate. So that stump will also remove. Now we started to see more into that cavity. I am now just gently debriding the uncinate here. I'm going to start opening into that sinus completely. So now removing more of that sinus wall. Now let's have a seeker. Let's have a ball seeker. See that? A lot of yellowish color in this tumor here. So I'm just going to point things to you. If you see, this is the wall of the sinus here. It's very soft, pushed by the tumor. Here is the tumor itself. And this is uncinate there, which has also been medialized a little bit by the tumor. And this is all within the cavity of the sinus now. So we'll debride the tumor a bit more, and we'll then remove more of that medial sinus wall. Now let's have 45 Blakeslee. This is more of the inferior sinus wall, as you can see. Let's try to remove some of that tumor a bit more for histology. So that's now tumor from the sinus. Interesting yellow color in it. Yeah. Let's check this. Whole tumor. It almost looks like orbital fat. It makes you worry, but it is not. Check the eye, obviously. Nothing happened when you're pulling that, but this is, sometimes you see with these inverted papilloma, that yellow coloration. Blakeslee again. Piece of bone. So here's a big part of the tumor, which tries to excise a lot of it. So we'll just take this out. All the bulk, we're just going to send it away for histology. Just to confirm, because doing this, you should get a lot of biopsies from this tumor, because you look for atypia, you look for any unusual dysplasias and so on, or focal malignancies, because you never know. Sometimes it would be something like this in association with an inverted papilloma. So that's why I'd like to actually send as much of that tumor for histology as we can get. Well, let's have the suction now. Let's actually check it first. Yeah, so we still have some of it here. So let's get some more out. Let's have Blakeslee again. Okay. So let's now debride a bit more and get a bit more access here, and then soon I'll be changing to a curved endoscope so we can look inside. So I'm getting into the floor of the sinus a little bit more now. Just removing this rest of the medial wall down here. The bone usually thin until you reach just about a millimeter or two before the floor of the nose itself. I will need 45 soon, not yet, yeah. The specimen is maxillary sinus. So let's, now I'm looking directly into that posterior part where we're thinking that exostosis was on the scan. So which is very likely to be the source of the tumor. So we're looking straight into the posterior wall of the sinus here.
Hisham, it doesn't look like very friable tumor, is it? Is it more of a fibrous component to it?
Fibrous, yeah, it is quite
fibrous. What's your feeling?
Yeah, they are like that often. So, and sometimes because they're so fibrous, the debrider wouldn't actually cut them. But it is working now. So I'm clearing more and more. So I'm gonna change into my angle scope now. If we get the 45-degree scope, but let's put some patties in for a second. Suction. So I like putting the patties on and off between procedures, between changes, scopes, and so on, decrease the blood. But sometimes it's very useful to also wash with a warm saline. It's okay. So we're going to change the scope now. I have a 45. So I complete. So what I do is, as you see, I do it step by step. I clear the tumor from the maxillary sinus, expose the floor completely. That's why I go down to the floor and expose the anterior wall. So I'm going to remove the rest of the maxillary medial sinus wall completely, so I can see everywhere. Because the bits that you can miss, the part of these tumors that you can miss, are the ones on the floor and the anterior wall. These are the most reasons for recurrence, usually these areas. If they're not cleared, you get recurrences. Let's change into curved sucker, the maxillary sinus sucker as well. So we're going to look laterally now into the sinus. So I'm looking inside now. So you can see the rest of that tumor here. Still quite a lot of it inside. Let's have a Huey visor. So I'm going to pull some more of it to send more for histology to the rest of it. Okay, more tumor. And let's have a Blakeslee 45. Interesting yellow coloration of all that tumor. Yeah, we'll just put it with the same one. There's all maxillary sinus. It doesn't look malignant to me, to be honest, but you never know because sometimes you get surprised. But as we remember, the biopsy from the clinic was benign inverted papilloma anyway. But we published a series of 69 patients about 5 years ago, and 6 of them were reported initially inverted papilloma, but they had malignancy. So that's why we are aggressive with these tumors. So I am, again, debulking, removing everything, but this is just the beginning because we have to remove everything. We have to expose, look everywhere, and then drill into the periosteum itself as well. So not just removing the tumor like this. So in a minute, I'm going to remove more of the anterior wall and more of the floor. We have to be careful this area because intraorbital nerve will be here. So just leave it for now. Okay, so can I have a backbiter? So I'm going to remove a bit more of the anterior wall. So basically, I'll use a backbiter to remove all this thin bone, really, until I reach the anterior wall. Okay, Here you go. Just stick them and I'll use it again. Now, if I'm pressing here on the lacrimal sac. So this is the opening of the lacrimal duct here. Can I have a seeker, bull seeker? I'll just show you something here, because this is what we're going to keep flush. So there is the lacrimal duct opening. And as long as you make sure this is open at the end of the procedure, you'll be okay. Yeah, so here, it's cut flush here. So just make sure it's open, and then you'll be okay with avoiding epiphora. So let's have the backbiter again.
So Hisham, can I ask you, how do you decide about whether you want to preserve the mesolacrimal duct or
if the papilloma is if the papilloma is very small, is not extensive, is not filling the sinus, and I can see exactly where it's coming from, I preserve. But so for many years doing this before the pre-lacrimal approach was described, in many cases I've had one epiphora actually, and the reason is I think because I do check the nasolacrimal duct in the end and make sure it's open. So it's not common to have epiphora despite cutting through the lacrimal duct like this. So that's why I feel more comfortable having an extensive approach to see the floor completely and to see everything and anterior wall. So that's why I do pre-lacrimal approach only if it was a limited papilloma, basically.
Okay.
So there's a bit of thick mucus we've seen here as well, or probably infective. Let's see this green stuff here. So maybe that will be sent to microbiology. So let's get that for microbiology then. Just have a Blakesley 45. So maybe that like Pseudomonas almost looks like that to me, that green pus. And remember the patient complained of green discharge as well. So we'll get some of this out. Yeah, get the green stuff to the micro. It's mixed with the, let's give you that tumor first. It's quite soft now, this bit's here. So we'll just get it out. Let's have a straight Blakesley. That's a nice one.
Yeah.
So a big lump.
So this is from my area.
Yeah. So now let's have a suction. So clearly there's infection on top of everything else, which is not unusual. Now I'm gonna check again and look. So if you see, we can see the floor here. But I'm gonna lower it down, further down, so I can see further into the floor. Can I have the freers? We'll need a DC arbor. I will drill down here to get to the floor. So I just lift this mucosa off from the floor of the nose itself. Just medialize. Actually, the floor is so thin, I may not need to drill it. Can I have a Blakesley, just a straight? Looks so thin to me. So just remove the spits here. Suction. Yeah, it's very thin. So let's have this. The brother maybe we'll just get it out for this. I'll just debride some of that mucosa so I can expose a bit more. Yeah, now let's have a drill. Yeah, I do need it. Anteriorly, there's a bit of thick bone. So I can rotate my scope like this. I can look in the floor. And I can rotate and look in the roof. Now it's the infraorbital nerve, just like a 12 o'clock here. It's not very prominent, but we'll have a look at it again. Let's have the longer sucker for the frontal sinus sucker, the curve sucker. You see the bone here? This is what I'm going to drill. This one? No. Speed. So this is a small 2.9 millimeter burr, just to drill a little bit here. Slightly of that, just to have a complete exposure. Actually, the bone is really thin, and I suspect it's because that inverted papilloma was pushing into it. Suction. Let's connect to the bladder again. Actually, this bone is so thin. And we'll probably, at some stage, we will need the finesse burr, 40 degree.
40 degrees finesse.
Hisham, we are joined by Dr. Sunil from Ahmedabad. He has a question for you. What is the meaning of medial ligation of sphenopalatine artery in this case? Would you like to take that? Yeah, thank you, Dr. Sunil.
Sorry, I didn't get the question.
What is the meaning of medial ligation of sphenopalatine artery in this case?
What? To decrease the bleeding. Otherwise, it will bleed a lot because there's branches into the turbinate. So basically, when you start and by removing the turbinate, it will bleed very heavily if you haven't done the sphenopalatine artery ligation. So it's decreased the bleeding, interrupt the bleeding. I mean, you can see there's still bleeding here. But if we didn't do the sphenopalatine artery, it would be much more bleeding than this.
Okay. And Dr. Abdul Fatah, he's joined us from Tripoli, Libya. He has a question that, have you noticed any marked hypertrophy of the maxillary mucosa on CT after medial maxillectomy? Is it significant?
Guys, what question? I didn't hear as well. Sorry.
So, have you noticed any marked hypertrophy of maxillary mucosa on CT after? Yeah, so they're asking about the postoperative medial maxillectomy cavity.
You get hypertrophy, you can have the backbite. Hypertrophy of the mucosa initially, but then it settles down, thins down. And often you get some osteitis as well after this surgery. So you get osteitis with basically thickening and narrowing of the cavity. The cavity gets smaller.
Okay. Thank you. Yeah, thank you, Dr. Abdul Fatah. You joined us from Tripoli, Libya.
So I'm removing some of the part of the floor as well. So expose this.
Dr. Sunil also wants to know that.
Now look, this is the anterior wall of the sinus, so you can see it.
Okay.
So I am on the anterior wall of the sinus as well now.
Okay.
So let's have a debrider.
So Dr. Sunil also has the further question. He's logged in from Ahmedabad. He wants to know that why have you not chosen a Denker's approach? So, i.e., what is your indication for going for Denker's?
I didn't get this one again. Sorry.
So he wants to know that why did you choose this approach, medial maxillectomy, and not the Denkers?
Sorry, Ashok, I didn't get it. The bride is very loud.
Okay. Sorry, we'll get you at the, we'll let you carry on with the surgery and we'll take the question later.
Okay. Can you take it out and connect the finesse bar? So I'm showing you here that I have a complete exposure of the cavity. Is on infraorbital nerve. Looks safe. This is where the tumor came from. This is the exostosis that we saw on the scan. Look, this area here. See the prominence here. This is it. So that probably was the source of the tumor. We'll drill it later on. But I want to make sure that my final exposure is clear. It's a bit of pigmentation here. So I can see the floor completely and the anterior wall now. I just want to make sure I drill this a bit down so I'm on the floor itself. And then I have complete exposure. Then I'll start removing that mucosa. And then I will start drilling onto the bone. So can I have the drill? So now this is a 40-degree drill burr, which is what we call a finesse burr, which is used for the frontal sinus, but I find it very useful to drill into this area. So just to drill here. So just, I want to be on the level of the floor of the sinus, of the nose. And make sure the irrigation is working. It seems to be a bit slow. So I'm just getting myself into the level of the floor of the nose. Then I can't drill anymore after that. Just to make sure that I have maximum exposure. So let's have a look now. See, the floor of the nose is here. So I'm the level of the floor of the nose. And this is inside my cavity. So I can see everything now. If I rotate my scope, so I'm looking directly on the posterior wall here, where the blood is, because obviously the patient is lying on the back, so you can see that. This is the floor of the sinus. If I go like with the scope, I can rotate round. Let me just clean it, and I can show you all the angles. So I have complete exposure, so I can see every little part of that cavity. Like this, I'm looking into the cavity all the way onto the floor anteriorly. You can even look below the medial wall here, and I can look at the anterior wall. All this is anterior wall there. So I'm going to clear the rest of the tumor, and then after that, see the bit of tumor superiorly there, and then I am going to remove the mucosa. So now we need to change to the debrider, the curved 40-degree debrider.
40 debrider.
And could we have some warm saline?
Warm saline.
So I'm going to irrigate this, because irrigation, obviously, number one, warm saline will decrease the bleeding. And number two, I'll wash all these thickened mucus and pus and all that, wash it away. When we will clean this part a little bit, I have not opened here because I am right in the frontal wall and the anterior wall here anyway. So I don't need to cut into the nasal lacrimal duct any more than this. We know that very likely it was coming from here. So that is the area that we have to tackle. So this is now a curved debrider, which I'm going to use.
Wash now.
Oh, let's wash first, yeah. So I've got some irrigation. Can I have a suction as well? Irrigation is going to be very useful. So this is warm saline. It's good. And let's have a bit more. See, if you see what happens actually, immediately you see less bleeding. Why does warm saline work? What's the explanation? Supposed to be a vasodilator. Why would it actually stop the bleeding? Because it stimulates coagulation cascade, basically. This is what happens. So it stimulates the coagulation. Warm temperature does that. But also there's a theory it probably causes a bit of edema in the mucosa and compresses the vessels. So you see what happened here? So it has decreased the bleeding. So now let's have that curve debrider. So we clear more of that tissue. So I'm just clearing everything now. I'm removing the mucosa around the cavity of the sinus. You see, all this mucosa comes off. So you have to do this. And that is the area where the tumor was coming from. So we are gently removing the mucosa. And you really have to do this. If you don't do this, it could be microscopic tumor within this mucosa that would just recur. So I'm very gentle here. I'm near the infraorbital nerve. So I'm not putting any pressure. I'm just basically taking mucosa off. All these patients have to be warned about the infraorbital nerve numbness. Obviously, you try to avoid it. But in some patients, this tumor will be either involving it or just causing pressure on it. So, but you don't want to damage it by your surgery unless the tumor is in there. So it's just getting the mucosa off everywhere.
Hisham, we just discussed about how much mucosa do you remove in this situation. I mean, we also had this discussion with Prof. Paolo Pastano yesterday. So what is your view on that?
I still didn't get the question. I don't know if the voice is clear. Where is Priscilla? She needs to tell me the question.
Do you want me to repeat it, or somebody got it in later?
Sorry, Ashok, we can't hear. Maybe we should change our system a bit.
Okay.
Hesham, are you wearing the headset?
He is. I think the volume's coming from behind him and he can't
Yeah, I'll
hear.
wear the ear.
Just repeat it again and I'll listen.
So, how much of a sinus mucosa do you remove? We had this discussion with Prof. Pastano as well yesterday. So, what is your strategy for that?
Can't. I'm really sorry. How?
Okay.
We can't.
We'll type the question. We'll type the question in the box.
Perfect. Okay. Sorry, guys. I don't know why I can't hear. Now, let's have a look around. So I'm looking around everywhere. So I still have some on the floor here. And let's look at the roof as well. Yeah, mucosa on the roof here. And the floor. So let's work on the floor a little bit. So we'll also need the 60-degree debrider soon. I remove all the mucosa. Yeah, I don't preserve any mucosa in the sinus, especially where the area I suspect the tumor was coming from. So I remove everything. I'm just here, just removing the rest of the bulla, basically, just to create drainage. So you can see, I mean, this mucosa looks normal. So you don't have to remove all of it, but I tend to remove as much as I can to prevent recurrence, because you never know, it could be multifocal, these tumors sometimes. Although in the great majority, the area they're coming from is the bit that you have to remove. And we can luckily see, because you don't always see that on the scans, the area of exostosis or hyperostosis is where the tumor was coming from. Let's unblock the bridle, or maybe we could be ready for the 60 degree. So you can see now, this is just bare bone, all this in the posterior wall here, and this is got a bit of mucosa on it. I'm going to drill it with a drill soon, after I remove the rest of the mucosa. Now, I changed my debrider into 60 degrees so I can reach further. Just a little bit on the roof here. Do we have a 70-degree scope as well? Often I use the 70 degrees to look more anterior, and to look on the floor sometimes it helps. So I am actually on the anterior wall here. This mucosa here. So the papillomas that are coming in the anterior wall, they're the hardest to remove completely and to see everything. So these are the only ones that there is an indication, very rarely really, is to do a canine approach, like the old-fashioned Hardware so you could reach that. But to be honest, I've only had to do that once to reach into the anterior wall. So most of the time you can still reach by your complete dissection like this. I am on the floor now. Sometimes rotating the scope like this, you could see more. So I'm moving the mucosa on the floor. And if you see what I do it here, I rotate the scope so you can look directly onto the floor. Looks healthy, but I'm just going to drill a bit here, or debride a bit here. You can also see the medial wall of the sinus and the mucosa there. Now this looks normal. There's no debrider designed to reach this angle, but frontal sinus curette, please. I use the frontal sinus curette in this area here, the one with the most curve and usually you can just basically dissect this mucosa out like this. And when I've done that, I can just remove it. Let's have it brighter. Okay, so now I'm gonna wash it again. There's a bit of blood. Can I have the hue before wash? Have the hue visor for a second. So just remove that part of mucosa anteriorly here. Then I'm gonna wash it. I think I removed the majority of the mucosa I want to remove. And next thing will be for me to drill into the hyperostosis and drill the rest, then done. So we are getting toward the end of the procedure. But the most important thing is not to forget to drill onto the periosteum. Sometimes the suction is very useful to dissect as well. Just remove that little bits of mucosa that's a bit stuck. You can do that. Let's have the wash. Just wash it a little bit here. Take this mucosa out first. So let's wash it now. And then we can connect the finesse burr. And I will need the 70-degree scope and also the 70-degree bill.
70 degrees.
Burr, the one, and the burr.
70 degrees, but
So you can see the cavity now, bare bone everywhere. Bare mucosa here, we can remove.
just have it either 40, 120 or 90.
Can I have a look? Just bring them here. Let's have this one. So now I want to drill this hyperostosis area. Yeah, that's it. So that's very likely where the tumor came from. So I want to get it flat. So let's do that. Let's see if this is working. I just want to check 1 second. There we go. Suction for a second. So have a close look. This is a thickening, which is unusual, which was shown in the scan. It's a bit vascular as well. And I will drill it down. It's got an artery behind it. We'll diatherm it probably soon, but let's just drill into it gently first. I'm not on full speed because I don't want to go through the posterior wall of the sinus. Have a suction again. Maybe I'll have the diathermy actually. Yeah, let's have the bipolar. You can see why this is a source of a tumor. Yeah, should be about 10 minutes, I think, or 15. So we'll just diathermy this quickly here. Yeah. Post-operative care. A lot of washing, sinus rinse, strong painkillers. This surgery is painful because of the drilling into the bone. So strong analgesia and a lot of sinus rinse. I tend to give them antibiotics as well, just to make sure they don't get infection after all this exposure of bone and so on. And that's it. Everything else like normal sinus surgery. See, I planted it. I'm gonna do a little bit more here. So drill again. Suction. I think this step is essential, this here, because that is likely to be the source of a tumor. And if you leave it, you may have some microscopic recurrences. So I just want to flatten this. Yeah.
Catherine is typing questions from the audience.
Yeah.
Do you pack the cavity?
Yeah.
What's the post-op care regime?
Yeah, we pack. I'll show you. I will pack it with nasal pore. The post-operative regime is a lot of nasal, a lot of washing, a lot of irrigation is essential, and the patient may need to irrigate for about 6 months because they get dryness and crusting for a very long time. Strong analgesia because there's a lot of pain in this surgery, and short course of antibiotics just as a protective measure from infections. That's it. Nothing else special. And these patients still go home same day. That's the arterial bleeding here, which will diaphragm in a minute. Let's have a patty first. So I have drilled that bone now. That's the hyperestosis where the tumor was coming from. And that probably was the arterial supply of the tumor, that's bleeding here. So let's press on that, then we'll diaphragm it again. So, yeah, I'll take it in a second. So the final step after this is drilling into the periosteum, around the area of the tumor mainly. So just a very gentle thinning of the periosteum to prevent any recurrences. Suction.
You have the 17
No, in a minute. Yeah, let's just have the. So obviously the bleeding is in the bone, so it will. We can't diatherm it. We'll stop with the packing anyway. But let's try to diatherm it again. So this is my third
Thank you,
hand.
Hisham. That is great. And you see there how we
Yeah.
are drilling over the site of attachment and securing the hemostasis. Then we'll be using nasopore to pack the cavity.
Yeah, just for the
And
nasal
thank you
pore.
and also thank you for updating on your post-operative care and surveillance. So probably if that is all right with you, we'll make a visit to Dr. Satish Jain in Jaipur, India, and see how we're progressing with the second case. Thank you. So what is the next case over at Charing Cross?
Our next case is going to be in intracoronal polyp. Can we decrease?
Okay, great. That will be fantastic.
Decrease the irrigation.
We'll see a different approach to maxillary sinus as the pathology is different.
Have the.
So thank you. So back to the studio and let's check with Dr. Satish Jain for his next case.
So I'll be just 5 minutes basically. So I'm going to pour the.
Hello, welcome back to our GRN studio in Winchester. So those who have joined us a little late, I have with me my colleague Catherine Drenny. So Kath is consultant rhinologist, skull-base surgeon from Imperial College Healthcare Trust, Charing Cross Hospital. So thank you, Kath, for joining us, and I hope you're enjoying the surgeries. We've had two brilliant cases so far, haven't we? You're muted, Kath, probably. Kath, you're muted. Can't hear you.
Sorry, can you hear me now?
Yes, we can hear you.
Sorry. Yeah, no, they've been really nice cases. The chronic rhinosinusitis with the allergic fungal mucin and the polyps that we saw, and then the inverted papilloma. So really nice to see that as well. So a good example of a medial maxillectomy, and nice to see that area of hypostosis with even the blood supply coming through the bony area to supply that tumor. So really interesting. What have we got next coming up in Jaipur?
I think it is sounds like another case of chronic rhinosinusitis with nasal polyposis with a different type of presentation, probably. So let's check with Nagpur whether they are ready, and then take it from there. So far we got 4 hours of live surgeries, and many more to come. So I think there are 2 more cases coming from Dr. Satish Jain, and a few more again with Hesham from Charing Cross. So okay, we are with Dr. Satish Jain again. So Dr. Satish, can you hear us?
I think you might be muted at the moment. I have to wait and see if we get in touch.
We'll check with Dr. Jain whether they're ready to join us. So, Kat, talking about Hesham's next case, the antrochoanal polyp. So essentially, again, it's a maxillary sinus pathology. So what do you think his approach is going to be like?
I think for something like an antrochoanal polyp, he'll be less aggressive than he's been for the inverted papilloma. Because obviously there's no malignant potential there, although they can recur. And I think he'll hurt more. I would try and get it out through a large maxillary antrostomy if I could. And obviously, even with the antrochoanal polyp, you want to get rid of that point of attachment for them to prevent it recurring again in the future. But I imagine the patient had a similar presentation. So, presenting, seeing a GP a number of times or a family practitioner a lot of times with a blocked nose and trying nasal sprays without anybody having looked in the nose yet. And then obviously, as soon as somebody looks in, we can identify the pathology straight away. So quite a lot of these patients have tried a number of things before they even end up with ENT, unfortunately.
Okay. And how do you try and mitigate any possible recurrence? What's your surgical plan for that? Have you seen many AC polyps recurring?
I've only seen one that's... Oh, I think we're back in. Hello?
Hello.
Hello? We're connecting to Nagpur. Hello, Dr. Satish.
Yes, sir.
Can you hear us?
Can you hear
we are
me,
back
sir?
with you.
We're
Yes.
back with you.
Hello,
we're
yes,
back
yes.
with you. Yeah.
So,
Me and Catherine both are back with you, and we are connected again, and look forward to this. Already looks like a very interesting case on our scan.
sir.
Yes.
So the last case, you had seen only one side. After that, on the other side, we did a limited septoplasty and a full ulcers as well.
Thank you.
So this is the new one. Next case, again, as a middle-aged male patient having bilateral massive polyposis, massive inflammatory profile, pure eosinophilic disease, and I'll take you to the positive findings of the scans quickly. We have discussed the scans in detail in the last case.
Yes.
So in this case, if I go from anterior to posterior, see, you can see so anteriorly, the entire nasal cavity is blocked by polyps.
Yes, sir.
See the opacity far anteriorly blocking the entire nasal space, particularly on the left side. And now on the right side, see, the nasal space is completely blocked by the polyposis. You can imagine the inflammatory profile of the patient. Bilateral full frontal sinus opacification, left bigger than the right one. See frontal beak. Now the beak is going. This is the frontal drainage pathway. Not like previous one, not a big supraorbital recess. The right side is very narrow, small supraorbital recess. And then as we go behind the cribriform plate, see this complete whiteout picture. Bilateral pen opacification. See the septum, if you see, septum looks in the midline because of the polyps on either side. The turbinates are all compressed, looks compressed. See this turbinate looks compressed. This happens mostly in massive polyposis because of the compression. The normal structures get compressed, turbinate, bulla, all these things get compressed. This is your cribriform plate. As you go behind, now is the beaking of the orbit. See this beaking? This is anterothoracic artery leaving. This is superior oblique, this is medial rectus. And the artery leaving the space towards the cribriform. And immediately after that is the posterior third starts. Pen opacification. You cannot discriminate even the bony structures, even in this bone window, because it's so completely compressed with the polyposis. Posterior thoracic cells, little bigger cells. You can see these bigger cells going behind. See, this is the level of the sphenopalatine foramen. This is infraorbital fissure, the orbital apex. Opacification of bilateral sphenoid sinuses. So this is basically, you can say, pen sinusitis. Massive disease, and once again will be requiring a full house FAS only. This is soft tissue window I was talking about in the last case. See now the difference between that and see the bone window and soft tissue is. The soft tissues, look at the brain, look at the orbit, intraorbital structures. The soft tissues are prominent everywhere. See even the outside muscles, pterygoid muscle. Let me keep both the windows together. See this. See in this bone window setting, only the bones are prominent and rest of the soft tissues are not very, I would say, in terms of discrimination, not very useful. Here, the bones are not defined, but the soft tissues are very, defined. You can discriminate, see even in the brain, the discrimination in soft tissue as compared to the opposite side. Intraorbital structures, see the muscles, orbit, muscles of the mastication, structures surrounding the paranasal sinuses. The soft tissues are more prominent, and ideally we should have both in bone and soft tissue window settings once we order a CT scan. So this case is straightforward, bilateral massive polyposis requiring a full house FAS. Anything you want to discuss before we start? In a couple of minutes, we are going to start with the endoscopic picture. Anybody? Dr. Okade?
Hello.
Yes.
Good afternoon, sir. This is Dr. Ram Heda.
Yes, sir, how are you?
Yes, sir, fine. Just wanted to ask one thing. When do you advise CT after giving a course of steroid or directly?
Yes, so that's an important question. Whether you advise upfront CT scan or after the course of medication. See, this should be very clear to everyone. In CRS, or basically CRS is diagnosed basically on the clinical ground. And the diagnosis is, further, confirmed on the basis of endoscopy and then CT scan. So CT scan is not a primary thing to diagnose, CRS. CRS when diagnosed on clinical grounds should be offered medical treatment. If you have slightest doubt on the diagnosis, or if there are unusual symptoms, or if patient is not responding to the adequate medical management, or turning to complications, those are the times. And most importantly, when all medical treatment fails and surgery comes to the question, or surgery is the answer, then we should get a CT scan done. Now, the proponents of upfront CT scans are there and they have their logic. If you have a doubt of a fungal disease, there is no point in giving unnecessary medical management. The cost of medical management and the time and money ruined is not justified. So in those situations, upfront CT scan is useful. It all depends upon the patient profile, diagnosis. Even if we get upfront CT scan and it responds to medical management, there is no harm in it. But if it doesn't respond to a need of surgery, you don't need to repeat CT scan because the anatomy is never going to change. So if you have done an upfront CT scan and later on after a long time, if you want the patient wants a surgery or need to be operated, you don't need to repeat a CT scan because CT's role is mainly to give you anatomical details.
Yes.
Anything else?
It's probably a good idea to know what was your preoperative medical preparation for this patient. Was it any different than your previous patient or was it the same?
See, this patient requires a course of oral steroid, saline wash, steroids, and of course the immune assessment. We always follow all these CRS patients for immune assessment. Up to 10% of such patients have some or other deficiency in the immune system, which is responsible for the, virulent course of the disease. Such polyposis patients should be thoroughly asked for the aspirin sensitivity as well. If they are sensitive to aspirin, however number of times you operate is not going to cure the patient because the fault is lying in the arachnoid acid metabolism pathway where the patient is, hypersensitive to COX-1 inhibitors, leading to more and more leukotrienes secreted, which are driving the inflammation. So in that situation, even if you operate, the surgery is required, you can give access to the topical, but still the inflammatory load is so much in those patients. Unless you don't desensitize with the aspirin, the surgery is rarely going to work alone. And those patients will require repeated surgeries, biologics and more extensive treatment. So assessment of the patient should be, on a close watch to keep an eye on the immune system, to keep an eye on aspirin sensitivity. See, CRS polyposis looks one disease, but it's not one disease. There are a number of endotypes defined now. Endotype means number of variety of CRS having different underlying pathophysiological process going on, which ultimately require a different treatment lineup, different post-operative course, different prognosis, and everything different altogether. Like for example, AERD is a different endotype. AFRS, I mentioned about it in the last case. allergic fungal rhinosinusitis is a different endotype. It requires steroid as a mainstay of treatment and